I just want to get started by welcoming everybody, and I'm Alan Goldstein. I'm the Chief of Pediatric Surgery here at MGH, and our first speaker who will make introductory remarks is Eric Schnadig, who he and his wife are the founders of the REACH Foundation. They have a child with Hirschsprung's, and they have really made a huge commitment to make a difference in this disease. Eric?
First of all, thanks for coming. It's great to see a group of people that care about Hirschsprung's. Welcome to the second Hirschsprung Symposium. As Alan said, my name's Eric Schnadig. Almost 3 years ago, my wife Isabel and I founded REACH, REACH Hirschsprung's, REACH for short. And REACH stands for Research, Education, Awareness, and Awareness for Children with Hirschsprung's. It's a not-for-profit organization, and our mission is quite simple. It's first to improve the lives of children and families who are dealing with Hirschsprung's, and second, to find a cure. Our inspiration, as Alan mentioned, for founding REACH was the birth of our fourth child, Adrian, who was diagnosed with total colonic Hirschsprung's at 4 days old. Fortunately, he received expert care right here at MGH under the fine stewardship of Dr. Alan Goldstein. And we've been thinking about and now doing something about helping other parents and families who are facing the same challenges with Hirschsprung's ever since. We have a great program lined up this morning, and so I want to get right into it. But before that, I want to thank MGH for hosting us. I think that's all of you or some of you, but thank you, whoever you are, the MGH team. Second, I want to thank the REACH team. You guys know who you are. I want to thank the speakers who are here. Looking forward to hearing from you today. And then I want to thank all of you who came. Thanks for your time. We know you're busy. So without anything further, welcome again. And Alan, take it away.
Thanks, Eric. So our first speaker this morning is Dr. Daniel Doody, who's Associate Professor of Surgery at Harvard Medical School and one of our senior pediatric surgeons, shares an interest in children with motility disorders and especially Hirschsprung disease. He's going to talk about the challenge of Hirschsprung surgically, and is there a best operation?
Thanks, Alan. I want to thank the kind invitation from Dr. Goldstein and the REACH organization to talk today. Hirschsprung's has been a longstanding interest, and I'm particularly pleased that I'm having an opportunity to talk about it. When we were discussing different topics that we could potentially talk about, I had mentioned that, there's 100 thoughts, and is there a best operation? And I was queried about this by a parent, and I kind of thought, well, gee, I have my favorite, sort of the way I was trained. But is there really a best operation? And I'm going to kind of go over what we're talking about with the hopes that families who know about the different procedures will say, oh, my child had that, but these are other operations. Or I know so-and-so's child doing better because he had X operation and my child had Y. Is he doing worse because of that? So I'm going to try to reassure you that all of our operations have problems. Surgeons are simple souls. If there's a best operation, we're all going to do it. And the fact that there's 84 different operations to address Hirschsprung's disease would suggest that there isn't a best operation, but all of them have some advantages. As we are more and more asked to do, I have no financial disclosures. Our basic objectives, I'm not going to dwell long on number 4 here because Dr. Goldstein's going to be talking a little bit about the complications that occur after our procedures. I am going to talk a little bit about the different operations using diagrams to just kind of show it, so hopefully everybody will say, oh yeah, now I understand. I will tell you that our diagrams are not as clean as our operations, though, because they're not all color-coded, but you'll have an idea about what we're trying to do or what the surgeon is trying to do. We'll talk a little bit about the expected course and problems. We'll review the long-term outcomes from different operations. There's a series now that treatment of Hirschsprung's disease has been established for many years. We're actually seeing older patients, adults who had Hirschsprung's disease performed as children and how they're doing. And I hope that we'll end up with sort of a general idea about this. An exaggerated diagram, but sort of what Hirschsprung's disease looks like. And you could see the problem back at the beginning of the 20th century, end of the 19th century. What the surgeon was seeing is that there was this big dilated segment which was felt to be wrong. This contracted distal segment was thought to be normal. And all the operations were really to address this big dilated segment which was normal, but functionally obstructed by this contracted distal large intestine. So we really had an aganglionic segment that sort of extended and would often carry into this dilated segment. There was a transition zone most frequently, which isn't totally normal. So there's a transitional area that was kind of in this dilated segment. And then there was often a normal segment in front of it. So this normal innervation sort of carried into this wide dilated segment. Some portion of this was a transition zone. And one of the things to remember, of course, is it wasn't a perfect cylinder going across. You're like, this is the transition zone. Anything above this is bad. Anything below this is bad. Anything above this is good. But what we've come to realize is that it's more of a waterfall effect, and there's some nerve cells at different areas. And some centers are trying to do different innovative techniques to try to determine where is it really normal. And I would say that what Dr. Goldstein needs to do is find out some way of color coding it for me, because if I can get to the ganglionic segment, I can almost always get it down to the anus so that we'll do well. My problem is too often I'm kind of in this mixed area, and with the transition zone being different, it's a little bit of a problem. So the Swenson operation was the first operation that was described that removed the aganglionic segment but also achieved continence. There was other operations that were being done before that, but Dr. Swenson in 1947 performed the first procedure, and in 1948 reported it in 2 patients. And what that procedure entailed was he removed the aganglionic segment and the abnormal segment, and most frequently these children had been obstructed for a long time, so it was a big dilated segment, and Dr. Swenson actually went above the big dilated segment, almost for sure being in the correct area. Because remember, it carries over into the dilated segment. He then very meticulously dissected, removing the rectum, so he did a proctectomy, removal of the rectum. He basically everted the muscular coat of the distal large intestine and the rectum, cut it, brought the normally innervated segment down through his opening, sewed it in place in 2 layers, and then pushed the sphincter complex back in. I will tell you that it's almost impossible to pull the sphincter complex out, and I've tried. So I'm not quite sure how Dr. Swenson and his disciples have managed to do that so well and continue to have good continence. In 1956, Dr. Duhamel in France described a procedure that was quite a bit different than the Swenson procedure to address this problem, now identified as aganglionosis. And what Dr. Duhamel did was a little bit different. This dissection is a little bit easier. The surgeon can find this space in the sacral hollow here, kind of just bluntly dissect, lifting up the rectum. And what Dr. Duhamel did was he divided some portion of this and then brought normally innervated colon behind and actually brought it out and sewed it in place here. And Dr. Duhamel first just divided it and left it there, but what ended up occurring was this pouch, this old rectal pouch, became filled with stool and would often obstruct. Dr. Duhamel's original operation wasn't as nicely defined as the eventual Duhamel procedure. He actually kind of brought it down through the complex, behind the sphincter complex. Many of the children were initially incontinent. This pouch often filled with stool. But Dr. Grobe in Germany, Dr. Martin here suggested dividing that spur in between it. And so what he had was a propulsive, normally innervated segment and a very short segment of uninnervated rectum still in place, but not disturbing the sphincter complex in the eventual Duhamel operation. And this operation is really the procedure of choice in Europe. If you look at it, a lot of Europe uses this, and several centers in the United States use this as their preferred operation for the treatment of Hirschsprung's disease. And then in 1960, Dr. Suave in the Italian literature described his procedure in 1963 in the British Journal of Surgery, in 1964 in the American Journal of Surgery. And it's interesting, if you look at these original procedures, Dr. Bowley described a New York surgeon, described almost the exact same operation, the article after Dr. Suave's article in the American Journal of Surgery. So this was the endorectal procedure with a mild modification, and what they said was, look, the Swenson's operation is so difficult that we're having a lot of problems, some incontinence, some urinary problems, because we're disturbing the nervous system that's going down to the pelvic organs. And so what we're going to do is keep our entire pelvic dissection inside the rectal cuff. So what he ended up doing was removing the mucosa. So he actually dissected down, removing the mucosa from the muscular rectal cuff, not disturbing any of the pelvic tissue. He inverted this mucosal segment through the muscular cuff, and then did an operation very similar to what Dr. Swenson did, and those results ended up being pretty good, but technically it was more demanding. And so there ended up being the three major operations were the Suave, the Swenson, and the Duhamel, and that's what we see being compared more and more. Finally, in the last 20 years, we are doing laparoscopic operations or pure transanal procedures. I actually think there's an advantage to do it laparoscopically. And in this case, what happens is the colon is mobilized laparoscopically. We start a short Suave type procedure, but it actually ends up being a Suave Swenson, in fact, because we actually go up a short distance, dissect out through the rectal cuff, and then mobilize the rectal cuff, now mobilized laparoscopically, drawing it out through the anus, and then doing essentially the final anastomosis, which is the innervated colon to the anal tissue. And you can see the incredible length that can be achieved when you do this type of operation, mobilizing it. And you can also appreciate this is the contracted distal segment. This was non-innervated. Here's our transition zone. Here was normal ganglion cells here. This was actually a 5-week-old where the procedure was being performed. So you can really appreciate that even at 5 weeks, there's quite a bit of distension of the normally innervated colon as it's trying to get through this long segment of non-innervated colon and rectum. And at this very end part here, it's just the mucosa and submucosa. So we were trying to preserve the sphincter complex with this operation. So is there a best operation? Well, if you talk to most surgeons, it's like, oh yeah, they all do great. That's because we got out of our initial postoperative period, but if you talk to the family, and if you talk to the pediatricians and the pediatric gastroenterologists, you'd find well, a lot of kids do have problems. And I think that's where the surgeon has to be increasingly aware. And if you look at this large study, again, Swenson and Duhamel, this is from Finland, so they're really comparing what's being performed in Europe. Only half of the children have a perfectly good outcome. This really perfect sensation, I evacuate normally, I don't need laxatives. But about half of the children in long-term follow-up will have the perfect operation. Many have good. And the other thing that's become apparent is that some of the things is that it will be over time. This, however, shows what I think the surgeon needs to inform the parent. You can talk about bleeding and infection, which is what our house officers most frequently do. What's the complications? Bleeding and infection. That's actually not what the complications are. The long-term outcome is where our real problems are. Jarvie is from Dr. Rentala's group. They looked at 178 patients who have been followed for a long time, and what they found is over time, there was some staining in the underwear, fecal soiling. There was some incontinence in 1 out of 50 children who had operations for Hirschsprung's disease, and about 10% of children had constipation of such severity that they needed to have additional significant bowel management or additional surgery. Here's another article from Dr. Naramas. This is from Thailand, actually, but it's one of the biggest collections that not only looked over time, but looked at the different procedures. And what they did is they had 467 cases over 12 years. That's a busy hospital and medical center. 204 of the patients were available to study in that they were beyond a certain time point. 178 patients had short segment disease, and the reason that they chose that particular group is that children who had chromosomal abnormalities or who had total colonic Hirschsprung's disease were considered different. Perhaps understandably. We would certainly hope that we could get a really good result with short segment disease involving the rectosigmoid, and in some groups they include the distal descending colon, so a little bit of the left colon. So short segment disease, we would expect to do well. And here they broke up their groups. As you can see, the children at 15 to 20 years of follow-up were smaller than these other groups, but you could appreciate what they're looking at. If you look at the immediate and long-term complication rate, pretty equivalent for all the groups. About the only one that seems to stand out in the group is enterocolitis, seemed greater with Swenson's disease. I'm going to make the argument that from a clinical standpoint, that probably doesn't make that much difference. So that in fact, all of the complications seem to match out pretty much the same. One could also note that Duhamel operation, where you're not doing an end-to-end anastomosis between the innervated colon and the anus, has less stricture. Well, that's true because really you open up this big wide area between the common walls. So we shouldn't have an anastomotic stricture. In fact, the fact that they had almost 10% having an anastomotic stricture is a little bit surprising. But if we look at it, they used a standard score for bowel function quality, and 14 is perfect, 10 to 13 is considered good, 5 to 9 is fair, and 0 to 4 is considered poor. What we saw is Group A, 5 to 10 years, 67 patients. You would say, well, most had a good to very good result, excellent result, but there's some that really weren't doing very well. Group B, so that's 10 years and 1 day up to 15 years, you see that there's an improvement with several of them moving to more excellent and several of them moving into good quality. In Group C, where it's 15 years and 1 day to 20, they ended up having a very good result, excellent result in almost 90%. And I think this is kind of what many of us think, that if with time things do improve. Sort of quickly here, just to show the average age of follow-up, this is exactly that table. It was 8.5 years, 12.5 years, and almost 19 years of follow-up, with the 19-year follow-up showing an excellent result in almost 90% of the patients. I was curious in the same paper because they actually just broke it out in terms of the Duhamel operation, the Suave operation, the Swenson operation. And again, we don't see much results. The Swenson procedure, remember they have more enterocolitis, 100% had considered to have an excellent result, although the numbers are small. Perhaps the only thing that struck me is that in the intermittent group, this group here from 10 years, 1 day up to 15 years, there seemed to be some improvement to the Suave operation. But again, with small numbers, it's tough to say that it's clinically different. Overall, you would see that most of the numbers match up pretty well, so that there doesn't appear to be a significant difference. I'm not going to dwell on this very long, but suppose you said, gee, you know, doc, we've been patient, my child's still having trouble. Our group and several other groups across the country, it's not just our group, although I think we're best, are very interested in what do you do. So this type of flow diagram is sort of the things that we like to think about. Physical examination, contrast study, I think are very important. If those look normal, we have to consider a rectal biopsy. If that shows aganglionosis, not because the physician did the first procedure wrong, but because he might have been in the transition area, the distal colon is very sensitive to the blood supply, so bringing it down to the anus can be a problem and can cause loss of the normal innervation that was seen. So there's a bunch of advantages to the rectal biopsies indicated. We do motility studies, both x-ray studies as well as specific manometric studies. We consider Botox and have used Botox. We've used operative procedures. If it's a generalized dysmotility problems, we do occasionally have to consider an aggressive bowel management program and also some additional surgical intervention. So what are the conclusions? Well, is there a best operation? I'd have to say that experience as well as the literature seems to suggest there's no best operation. I like to inform the parents troiler training is often delayed by at least a year. About half of the children will not have a perfect outcome, and up to 20% will need some bowel management programs. Some problems with evacuation are common, but it tends to improve with age. Some problems, particularly those ones that it's not simple to manage, need more aggressive management and may include looking to see if there's mechanical problems, a twist in the colon, a stricture in your cuff if you're doing a Suave operation, a very tight sphincter complex, perhaps a transitional zone pull-through, or even an acquired aganglionosis. All of those things can be present, and the surgeon and gastroenterologist need to be aware. Children do seem to be at greater risk in certain groups, and that includes chromosomal abnormalities, those children who have postoperative or preoperative enterocolitis, and the group that has total colonic aganglionosis. One of the things that came from the literature, I didn't realize it was so long, is that as near as I can determine, that bowel movements tend to improve into adolescence, and then it tends to remain stable after that. And although it's mentioned in only a couple of the papers, it appears that in large series that have a lot of children who have been followed for a long time, that there can be some deterioration as you really approach the senior age group. But that's a very small group, and the operations done 40 and 50 years ago are quite a bit different than what we're able to do now. So what are my other conclusions? I think to really deal well with Hirschsprung's disease and associated neuroenteric disorders, you really need to build a team, which Dr. Goldstein and Dr. Belkin-Gershon and the group here has done. You need a pediatric surgeon. I think it's really important. You need a good pediatric gastroenterologist who's interested. You need nutritionists, nurse practitioners who can help you. I think psychologists and social workers are very helpful because functional pain is a real problem in this group with dysmotility. You have to include the primary care practitioner in their group, and the most important thing probably is to involve and inform the parents.